Good morning, everyone. Welcome to the last breakfast before our summer break, and we have a good one at that. Before we start, I am joining you today from Pickering, Ontario. I would like to thank the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples for the use of their land today. I am Matthew Hart, CEO for Longwoods Publishing and producers of these events. A couple quick announcements before we get started. You, of course, are welcome to use the chat, say hello, network a little bit. And speaking of networking, please feel free to reach out to any of today's speakers on their social media, whether or not that be Twitter or LinkedIn. Those are good places to start. To that, if you have any questions today, please use the Q&A function and not the chat. Questions are likely to get missed if you ask them in the chat. I would like to thank today's sponsors from Healthcare Excellence Canada. We have Miria Judd joining us, Leo Diaz from HEROC, Leanne Scott from Health Pro, Jennifer Pugnat from Roche. So a thank you to them for supporting today. Lastly, I will be sending you a link in the chat for all three reports, the third one of which is our focus today. Don't forget to download those reports if you haven't already when you get a chance. That's it for me. To guide us through this morning, I would like to welcome from the School of Public Health at the University of Victoria, Dr. David Castle. David, it's all yours.
Great. Thanks so much. I'm David Castle. I'm a professor actually in the School of Public Administration, not Public Health, at the University of Victoria. And I also work with the Office of the Chief Science Advisor to the Prime Minister as well. So I'm very glad to be moderating this event, and I come to you from the traditional territories of the Wasanich peoples out on Vancouver Island. And so this is a really great event, and I'm very pleased to be moderating some discussion around the third report of the Pan-Canadian Health Data Strategy Expert Group and the work that we've been doing over the last 20 or so months. So thanks again also to our sponsors, without which these events would not happen or would be a lot harder to make happen. So we're greatly appreciative of their contributions to these important outreach events. Joining me today are Jeff Nesbitt, who's the CEO of the Canada Health Information Management Association, Dr. Ewan Affleck, Senior Medical Advisor, College of Physicians and Surgeons of Alberta, Dr. Kim McGrail, Scientific Director, Health Data Research Network of Canada, and Dr. Vivek, Goel, President of the University of Waterloo. Our plan for this morning's session is to have fairly brief opening remarks from each one of the panelists so that we can move on to what we hope will be a lively Q&A session around this rich topic that we're going to discuss today. And so our plan then is to have Vivek, Ewan, Kim, and Jeff say a few opening remarks about the report that we've delivered, our vision, thinking about trust and engagement, and thinking about literacy and stewardship as we move forward. So we're hoping to move through these remarks fairly quickly so that we can take up approximately 25 minutes of our time, and then leave the rest of the session for Q&A. So without prolonging my introduction, then I'd like to invite Vivek, who has been our very capable chair of our expert advisory group, to give an overview of the three reports, focusing specifically, I think, on the third report and the recommendations therein. So Vivek, over to you.
Well, thank you, David, and thanks to everyone that's joined us today. It's great to see so many familiar names in the attendee list, and really appreciate your interest. So the link for the three reports has been posted in the chat. I'm going to just give a couple of quick overview comments on the genesis of the expert group, and focus in on some of the key recommendations, and then my co-panelists will flesh these ideas out. And we're hoping, as part of the discussion, we will get into, I think, the really existential question: what next, and how we can all work together to ensure that these ideas and thoughts get implemented and move forward finally after many years. So the origin of this work was at actually the very start of the pandemic, which feels like so long ago, towards the end of the first wave. There was a commitment amongst the first ministers to address some of the immediate data challenges that were being faced during the COVID pandemic, as well as a commitment to develop a plan for ensuring that Canada has the data that it needs at the local level, provincial, territorial level, and federal level in response to future health threats. And so that was the genesis for our group to develop the plans or the model for a pan-Canadian health data strategy to advise on that. We did a series of reports. In the first report, we essentially reviewed the last 60 years of similar reports. And many of you are familiar, many of you who are on this, I think, took part in some of those earlier exercises and so know what the findings were and what happened. And there's a consistency in the recommendations that we saw. In the second report, we really focused on the scope of what needs to be addressed, and a few key points to emphasize. One is that even though we came out of a public health crisis, what we recognized was there's no bright line between public health data and health system data. And as we look at some of the questions that we had to address, whether it's calculating vaccine efficacy or doing surveillance for variants of concern and looking at what the outcomes are from different variants, you need to bring together data from public health with the health system in close to real time if you want to be able to get at what's necessary. And so for our third report, where we landed was we recognize that the challenges that we have to address are not one of systems or technical issues. They are important things that we have to resolve, but we can't jump to those challenges without addressing some fundamental things. And first and foremost is really having a shared vision for where we want to go. And so we've developed a draft for discussion of a vision for a person-centered learning health system, and accompanying it a health data charter. And we think that having a vision for a person-centered learning health system will drive what we need to do in terms of the data. Because if we build a health system that is centered around individuals, and we use the term person purposely because it's not just patient data, it's data at all stages of the life cycle course, including when people are healthy, so person-centered. And a learning health system, one that's constantly improving and learning, has to have the data structured in the way that will also then support all the other uses that are important. Population and public health, health services management improvement, and research and innovation. And the charter, which is based on a series of other documents that are well accepted, well recognized, really gives us a North Star. Here's what Canadians deserve and how we need to organize things. And we think that these could be the basis for consensus amongst governments and amongst a broad range of civil society organizations. What we do think is really important to get addressed before we jump to the technical issues is, first and foremost, governance and accountability. How we make decisions, and if we go back from our lessons of the previous 60 years, if we jump straight to trying to figure out what systems to implement, and we don't know how we're going to make the decisions around how we're going to implement those systems across provinces and territories, across different healthcare organizations, we're not going to get the outcome that we need. We need an approach to developing our policy frameworks, and particularly policies around health data privacy, that will be consistent across jurisdictions And one of the things that we recommend in our second report is to shift from models of health information custodianship to models of health data stewardship. And by that, we mean it's important to protect privacy. This is what custodians have been charged with legally, but we believe it's also important to ensure that data are used to improve individual outcomes as well as population level outcomes. And finally, we need to engage with the population. We need to engage with Canadians in making the decision. So the governance, the accountability, I don't think we'll succeed if we don't have the engagement, if we don't have the trust of the population. My co-panelists will talk further about this. We need to improve data literacy throughout the system. And we need to work on all of this in engagement with Indigenous communities. We've been purposeful in our recommendations in not laying out how Indigenous communities should do this. They need to come to their own decisions through their own processes, but we also need to ensure that we don't leave out Indigenous communities as we develop our data infrastructure going forward. So with that, David, I'll pause and let you go on with our co-panelists.
Great, thanks so much, Vivek, for the overview, the synopsis. I'd like to turn to you now, Ewan, get your views about the vision that we've assembled as a group, and say a little bit about the charter that we've put forward for thinking about how we can actually advance the cause of person-centric health data in Canada.
Absolutely. Thank you, David, and thank you, Vivek, for those comments. It's a pleasure to be here. I'm coming to you from Treaty 6 territory today. And so Vivek used a few terms: North Star, common vision, the charter being a North Star. So I'll just use my few minutes here to talk about this notion of a learning health system really defined by the design principles that we've laid out in this proposed Canadian Health Data Charter. And so why is this important, and how will this help us move forward in this agenda, as Vivek says, as opposed to many very laudable prior attempts that don't seem to have realized their aim, their goal. So to explain why we think defining a set of principles is important, I think we can start by all agreeing. I mean, I don't think there's any doubt that health data in Canada is fragmented. That's sort of a truism. I don't think there's anyone who's going to debate that. So it is fragmented almost at every level. And this is something that is shared across provinces and territories, jurisdictions, between custodians. And as we know, this causes manifold issues, certainly with respect to the provision of quality services, research, population health, management, education, so forth. All sectors are unified in the challenges we face by the fragmentation of health data. And that this, as Vivek implied, was a theme. We realize that we're unified in our concerns across divisions of the health sector with the fragmentation of data. So interoperability sort of becomes a holy grail. If we had data that flowed where we wanted it to, when we required it, if we were able to consolidate it or pool it for research and public health purposes, that I think would optimize our ability. So the question is then, why is this? How did we get here? Why is our data so fragmented? First of all, is this a technical issue? Certainly there are technical components, but I would suggest that this is definitively, the genesis of this is not technical. We can look at just about any other industry in the world now, and they are able to consolidate and to technically leverage interoperable data. And yet we have had a problem here in healthcare. And in fact, I would suggest our decision collectively across all provinces and territories, because it's consistent, to deploy fragmenting technology was a choice we made. It was a design choice that we have engaged in for about 30 years. So really the fragmentation is really a symptom of our inability to agree upon set principles of system and technical design that actually result in interoperability. Because there is no doubt that the technology currently exists. That is not the impairment. So as Vivek said, our report focuses on how can we then achieve a mechanism or a means or a set of harmonized principles around an approach to our defragmentation or integration of health information. So why did we choose then to deploy, to the cost of billions of dollars and the current havoc we are experiencing, why did we choose to deploy really what amounts to custodial-centric or service-centric solutions that do not speak to each other? Why did we choose to do so? And I think if you analyze that, this will help bring us to the conclusion or a more apt problem identification. We have used historical, really analog age policies and governance models that have led us to accountabilities for technology and system deployment that have occurred on a service basis and on an individual province and territory basis without compelling anyone to build solutions that have data trust standards that compel them to share data. And so basically we have built a service-centric or custodian-centric health system that has 13 different visions across the provinces and territories. So this notion of patient centricity, or as Vivek said, we have chosen intentionally the notion of person centricity, is really a myth in Canadian healthcare. And I think we have to acknowledge that. We talk about it all the time, but it does not exist. We have certainly through an information standpoint or data standpoint, we have a service-centric or custodian-centric system. So right now, CIHI, Canada Health Infoway, Digital Health Canada are working on data trust standards to look at interoperability, technical standards. So this is very laudable and important work. It's happening 33 years after the launch of the World Wide Web, but it is happening, and that's a really good thing. There's a problem, though. No one is compelled to use those standards if they are created. There is no mechanism to enforce them. And we've set many standards in our federation before that simply end up gathering dust. So what is the mechanism? How can we harmonize our approach? And this is exactly what Vivek was describing. And herein lies the true problem. We need, as a collective, to agree on cooperative co-design of health data around interoperability or around a person-centric architecture, which will result in interoperability. And that really is why we created this charter. So the charter becomes a set of design principles around which we can join each other in a cooperative approach to system design. And it sets out very clearly those parameters that we felt were required to harmonize our approach. So it really becomes a unifying evidence-based statement that outlines foundational system design principles. And it becomes a point of departure for us to collectively harmonize ourselves around data system design. And is the start of a dialogue. So how are we going to set up a mechanism to do so? So fundamentally, as Vivek said, and I will stop now, but the issues are ones of governance that have bequeathed our fragmented system. So if we can look at governance and policy in our approach as framed by a common vision, we feel that this will lead us in the right direction. Thank you very much. And David, back to you.
Thanks, Ewan. That's a remarkably succinct and on point analysis of where we've been and how we've got to this point. And you articulate our common vision about the way forward. So I'll turn to you, Kim, now to give us some of your insights about, how do we generate the kind of trust and engagement that would actually enable people to go along with this vision and help to see it being implemented. So, Kim, a few remarks from you about these issues.
Great, thank you, David. Good morning, everybody. And I am speaking with you today from the traditional ancestral and unceded territory of the Coast Salish people. It's the Squamish, Musqueam, and Tsleil-Waututh nations. I am just picking up on some of the language that Ewan was using. We're talking about socio-technical systems that need to be interoperable, and some of this is technical interoperability, but we also need to layer that human interoperability on top of it, which is, I think, fundamentally so much of what Ewan was describing in the focus on person-centered systems. And of course, everything that we're doing in this has to rest on law and policy. We can't go beyond the bounds of what is acceptable by law. And here I'm going to start talking about the data flows and understanding that we have the technical systems in place. How do we move data around for the purposes that it needs to move? Because this is a complicated architecture and all the data will not be in one location. So in addition to the law and policy that will guide us, we will rely on trust of the many people that operate in the system. And part of this is because of this human interoperability component. We know that laws can be interpreted in different ways, and trust is fundamentally such a huge portion of whether we want to see data about us or data from the area that we are responsible for, say in healthcare delivery, in the hands of somebody else. So in addition to the trust piece, the data flows also, and the rules around that also have to be nimble, because the data system itself is constantly evolving. The things that we call health data today, we might not have even understood as possible data sets 10 or 15 years ago. And what people want to do with data is also evolving pretty quickly. You just think about machine learning and artificial intelligence, a pretty good example of that. So in other words, we're always going to have situations where we need to make normative or values-based decisions about data use. And what I mean by that is who can have access to what, for what purpose, under what circumstances. Part of that is about defining public good or public value that's often referenced in legislation and policy, but doesn't actually have a clear definition. It really is up to us to make some decisions about that. So all of this, in my mind, and I think in the way that we talked about the report, really relies on public and patient involvement and community involvement to set the actual rules around data access and data flows. So I'm just going to go through three I think implications of this. So one is that patients would have access to their own data in these systems. If we want to build trust in data systems and data flows, then it's hard to see in a person-centered system how we leave person access out of that. And certainly it's one of the things that we hear all the time talking to the public about first priorities. Data flows also need to be able to support the transitions that people make as they move through the system, which is one of the weak points when you have interoperable systems, is how does data actually cross from one boundary to another. So we need to make sure that those flows are working properly. And then the public involvement in the broader systems about how data are used will help us, not just with transparency. So this isn't simply if we just tell people how things are working, they'll feel comfortable and we'll earn their trust. It's actually involving them in the decisions that we want to make. And this would mean, as we recommended in the third report, actually setting up an ongoing public assembly. So this is not so much that we want to devolve individual transactional decisions to every person in Canada about data flows. we recognize that there's some good that comes from using data at an aggregate level, and we want to be able to support that. But that it does mean we need public voice to help us make the decisions about, especially the boundary cases where there's values involved, and to help us evolve the system as data systems themselves change in their content and the capabilities. So, and then just finally to underline what has already been said about First Nations, Inuit, and Métis communities and individuals, everything I've said would apply, but as Ewan said, this is really about finding ways to support Indigenous data sovereignty, letting the Indigenous communities define what they want this to look like, but ideally getting to a point where we have some interoperability across those different systems, and recognizing that people move from different spaces and we want the data to flow with them. So I will leave it at that, David, and back to you.
Thanks very much, Kim. So that's it's a lot of work to engage all of these these communities, develop this kind of trust and engagement and buy into the vision that that we've articulated. One of the things that I found very interesting in the work of our expert advisory group over the many months that we worked together was that eventually we had to come to a common understanding about some of the key terms and their meaning, and also to think about the vision as we were projecting it forward, what it actually meant. And I was thinking, you know, Jeff, this is such an important area and one in which you're actively engaged in. How much work do we actually have to do now to up our health data literacy and tackle the challenges of developing the competencies that we need to get at the stewardship model that we're interested in?
Yeah, thanks, David. And I'll recognize that I'm spending time with you today from the neutral Anishinaabe and Haudenosaunee peoples here in Kitchener, Waterloo. And it has been a delight to sit with the EAG and reflect on this for the 20 months from the beginning of the pandemic, as Vivek mentioned, to recently. And I think, David, it builds on, you know, what everybody has a common experience around, specifically in the last couple of years, that health information has really dominated media headlines, right? I can't recall a time in our past where it's been a dinner table conversation for Canadians. And I think ultimately that's allowed us to witness how data truly impacts the lives of people. And so it's been inspirational to sit with everybody and share this. And as we continue the national conversation on this, I think what it has done is truly highlight the need to improve what we've called health data literacy with not only the professionals, but also, as Kim mentioned, right, create those circles where we can advance the literacy of people of the country. And so and we see the results of this, or the symptoms of these gaps, right, from the public discourse around vaccine efficacy rates or vaccine shopping, right? We witnessed how public health discourse has become increasingly vulnerable to misinformation. And that misinformation is used as ammunition in debates around public health decisions. So Canadians, whether professionals in health systems or the people across the country, I think the report really has a touchstone in there about the need for better literacy to understand how information is being presented to them, but then the ability to look at it and interpret it and understand it. And so part of the discourse over the last 20 months of the group, there is a recognition that health information is also now very pervasive across all sectors of our economy. And I think that plays also into the literacy side, right? It's used across the country to deliver care, plan public health services, but also develop products in the private sector and to adjust policy to ensure we're solving the right problems. So in relation to workforce development, the report specifically calls out literacy as a key section in relation to curricular standards. This is the exciting part, is we can, and the report recognizes this, we can recognize that there's standards already there that can be leveraged, but curated and adapted and then scaled. And so by doing that, and by taking that mindset to adapt, curate, and adapt, we can then connect it to frontline care and new data functions that exist, focusing a little more on the data quality and data side and the story of the person relative and how to enable the technology to enable those stories. So we have an opportunity to address misinformation, mistrust, and also increase the literacy of people in Canada. In this way, we are using our educational standards, our educational system in Canada to invoke as a lever of change back into the health system. So we can innovate a little bit outside the health system and bring it and roll it back. And so the report really speaks to the fact that I think in the past, maybe we viewed health information management as an afterthought, right? Kind of the thing you do after. And I think with the advancement of what Ewan was saying around the learning health system, it's not just an output anymore. And it's very much an input because it recognizes the story of a person, of a community, and our country. And it goes deeper in the report to speak about data stewardship as a practice in health information that would be, as Vivek said, right, accountable to champion the access of data, but while ensuring it's protected for the individual and then leveraged for clinical and analytical use. So the roles are ironically very common in other sectors such as finance. So where we're able to leverage this type of practice area to drive reuse of data and policies and standards to simplify and scale productivity for system effectiveness. So David, I'll end by just saying, I think the report really speaks to that literacy is a key ingredient to not only building standards, but also public trust in what's developed. And it's imperative that the health system not only leverages that within the health system specifically, but also in a broader lens, because it's a key ingredient to evidence-based data-driven health policy in the country. So David, back to you. I'm looking forward to the conversation today.
Great, thanks so much, Jeff. So a question to all of you then, now that you've shared the analysis and the vision, let's suppose the analysis and the vision that's being articulated is true and it's good. And so we really nailed it, done our homework correctly, and we really do have a strategy that could solve a lot of the major problems and has traction, has the potential for having traction in the world. Vivek started by noting that our group reviewed 60 years of struggling to adapt our health system to make better use of health data in the interest not only of persons but the system as a whole, and to turn this into a learning system. So let's, have we just produced a report that will be another brick in the wall of 60 years of failure, or have we actually now got a truly implementable vision? And if so, what is it going to take to get us there? How are we actually going to make sure that we're able to implement this? So how do we move from, in other words, from governance to action?
I'm happy to kick it off, and David, I can also maybe take the first question that's been posted by Simon, because I think, as you just said, we reviewed 60 years of reports. So in our first report, we summarize the root causes, and so I won't go through all of them right now, but I'd encourage Simon to go look at the first report. We lay out those root causes, and I think the solutions or the recommendations that we have are structured to address the root causes. And I think the answer to why we failed is in the past is we tend not to try to address the root causes. We try to find the next shiny bauble, or this we're going to go out and buy this system and it's going to fix everything. And if we don't address the root causes, we wind up frustrated, as we have been repeatedly. I think the opportunity that's presented that is different this time, but the window is short, is the experience that we've all had through COVID. And as Jeff said, we had dinner table conversations. People have been talking about data. in our reports, we've presented case studies of how things would have been different if we'd had the right data at the right time. And we can talk about experiences for individuals, and Ewan can give us, unfortunately, examples from his practice about the unfortunate experiences individuals have had when data is not available in a timely manner. And we could talk about the experiences for us as a population. If we'd had timely data on the site of outbreaks, the site of transmission of infections, we would have been able to make decisions far sooner about which public health measures were working and avoided blanket lockdowns, which much of the country had to endure for long periods of time and repeated through multiple waves, when if we'd had better information, we could have made better decisions around that. And so with those kinds of experiences, we can hopefully build a coalition that engages the community, engages a broad range of stakeholders to say, we need to do better as a country, and then hold our leaders to account, first ministers, health ministers, to move forward. And that's why, we start with, if you don't have the common vision of where you're going to go, we lay out the vision, we lay out the charter, we're going to not succeed. And then as we move forward, we can see there are some clear signals. If you look at the mandate letters for the Minister of Health federally, if we look at the work that's being done across a number of jurisdictions, health data councils, various bodies, there is an alignment right now coming out of the pandemic. And so we need to look at what are going to be the next set of negotiations for federal transfers, and what advocacy needs to be done to have these concepts on the table, and to have federal transfers to provinces and territories be based around participating in the decision-making bodies and agreeing to accept the standards decisions. As Ewan said earlier, choosing the standards is not hard, but agreeing to choose them and agreeing to implement them. And there are levers that I think can get looked at to make that happen.
Thanks. Kim, Jeff, Ewan?
David, I'm
on
maybe
mute. Sorry.
Yeah, sorry.
Jeff?
Yeah,
So
go ahead.
I'm just going to tie a few of Vivek's themes together here. And David, you asked the question, how do we move from governance to action, basically? I'm paraphrasing. Well, first we got to get the governance correct, because if we don't, we're not moving anywhere very rapidly. We're not moving. And so tying this into what Jeff was saying, we as leaders in the health sector need to become literate about why this hasn't worked, right? Because we haven't identified the problem. And the problem is that we're building something without any standards. Different people are deploying different technologies here and there. There's no set principles. It's like having a hockey team in Canada and you have a different coach for every player, and then you expect them to come together, and it's always good in Canada, by the way, to have hockey analogies. But so you get all the players together for the game, and they each are coached in a different way. Well, how are they going to function? They can have Connor McDavid and Leon Draisaitl. It doesn't matter. They're not going to work well, right? So we need to harmonize we have to have one coach with one plan, right? Or else this is not going to work. So the way to achieve action is first to nail the governance down, and recognize that we need cooperative co-design across provinces, territories, custodians, and so forth, and probably need to flush the custodial model and reinvent it as a stewardship model. And as Kim said, we require human interoperability, all these human elements. You will not achieve data interoperability if we do not have human interoperability. That will fail. And we've proven that for 30 years. And we've invested billions of dollars imagining that the technology is going to save us from ourselves.
So Jeff, I'll just jump in here for a second. I was just noticing some things in the comments in the Q&A. One from Rebecca about how do we ensure the success of these reports. Well, that's what our discussion is focused on here. But the dissemination, please, by all means, send our work far and wide as you can, and come back and engage with us. And James Ganga had said previously about helping to defragment this system by tying it to health funding to generate more person-centric systems. I think that's exactly what Vivek was alluding to, is that the long game here is to actually have an agreed upon strategy between the provinces, territories, the federal government, First Nations, Inuit and Métis to move something like this along with some essentially person-centric performance objectives connected to funding. BGM had previously raised this question about proprietary attitudes, and this is where I want to come back to you, Jeff, about implementation, which is if people think that they own data, whether or not they're providing services or providing some of the systems, will this data stewardship actually help us gain traction with a person-centric model to help us drive away from that kind of ownership mentality?
Thanks, David. Sorry, I was on mute again. Yeah, I think ultimately we need to move the literacy of, and that's why I was pointed in my opening remarks around the importance of literacy in a cross-sector way, right? This impacts not only the public discourse and the public sector, but also the opportunity to leverage the private sector in this conversation. And I think if we can get ahead of the curve by educating people about data stewardship and the change from that custodian model that Ewan spoke about, right? That it's not a control thing. It is more, how do you actually leverage the data for good and have that shift in mindset and really move people's perspective and lens from one of control to sharing, collaboration, but still with a respect towards privacy. But it's being able to come together with that mindset, and I think it is a change of mindset that we need to go through. Maybe Ewan, I know you and I worked a little bit with a few other folks on the EAG on this. Do you have any follow-on thoughts on that?
Yeah, I mean, or I don't want to monopolize here. Kim, do you want to pipe in? You're good. Yeah, no, certainly, Jeff. Absolutely, the crafting of a new relationship to health information around the notion of sharing it is important. What's interesting in Canada, if you look at it, and we learned this in our through some members and the work being done at McGill University in particular, is we have a robust approach to legislative the legislative approach to health data with respect to privacy and security in Canada. But what we lack almost absolutely is any imperative, legislative imperative, our obligation to share data and use it for the safe outcomes of Canadians. Right. So it's like a blank area. So it was an insight that I think we had. Often privacy gets accused of being the impairment to effective use of data, but really, I think often what's happening is there's a lack of compulsion or policy or legislation around our obligation to share, and this is what Vivek was talking about. So we need to develop, and this is what the whole stewardship model is how can we actually balance our need to protect individuals from breaches of their information against our need to protect them from damage that may be arising from a lack of sharing of data for the quality of their care and for effective research research in population health, and that will inform us as a collective how to provide better health care. So that's this balance that is missing. We're all skewed to one side where anyway, I'll stop there. David.
Yeah, I'll just turn to Kim then. Kim, you think a lot about the way that health systems and data need to be architected to get different kinds of preferred performance outcomes. B. Gupta had asked in the chat about this issue that our system architecture seems to be dependent on the way that it's funded, and that's a key driver in the way that it's structured, in the way that we do things, and it has implications for person centricity in the way we handle data. What's the alternative? What could we do better? How could we reorient the system? What are some of the key principles you'd focus on?
Yeah, I'll be really quick about this because I know we're reaching the end of our time. But I think, this is kind of response to another bit in the Q&A. One of the things we have to do is be really smart with the way we procure technologies and that sort of thing. So if we agree on standards, then standards can be part of what go into contractual agreements for technology providers, so that we make it clear that you have to be able to produce interoperable data that will flow at the request of the data owner, not at the compunction of the technology provider. So it's sort of flipping that around. And then I think on the other piece, we have to have a system. If it's patient-centered and if it's a learning health system, then it will follow that data will flow with patients. So we have to get out of the institutional morass there. But honestly, the other thing if we were a learning health system, then it will be clear to hospitals, for example, that understanding the effects and the performance of hospitals depends on understanding what happens to patients when they go back to the community. And so the data flows will become important for each of those individual institutional providers too, because they can learn from the whole of the system and the whole of the experience of people. I'll leave it there.
Great, thanks so much, Kim, and thanks Vivek, Jeff, and Ewan, all for your remarks, and thanks everyone for joining us today for this session, and to those of you who posted questions in the Q&A chat window. So with that, I will turn the floor back over to Matt. And Matt, thank you very much again for hosting us this morning, and your final remarks.
Thanks, David. And again, thank you to the whole group. Just quickly, I will forward all the questions that were asked off to the group, so there may be opportunities for them to address them, whether or not it be through social media or other means. As mentioned, this is our last event before we take the summer break, but coming up, just to let everybody know, we will be having Adelstein Brown, or Steiny Brown, from the University of Toronto, John Yip from SE Health, and Michael Gardam from Health PEI. So keep your eyes out for those. Other than that, fantastic day, enjoy, and we will talk to everybody soon. Bye-bye.